Hello, everyone, and thank you for joining us for a special installment of our Policy Lab webinar series. Policy Lab is a research center within Children's Hospital of Philadelphia's Research Institute, and during the month of May, which is Mental Health Month, we'll be focusing several 15-minute webinars on various topics under the umbrella of behavioral health. You can see a list of the topics we'll be covering on the current slide, as well as a link to the landing page where new webinars will be posted throughout the month. We encourage you to visit our website, policylab.chop.edu, for more information and to share these webinars and other resources via Twitter, tagging us at @PolicyLabChop. Today we'll be focusing on the benefits of integrating behavioral health into primary care and hospital settings with Dr. Ariel Williamson, a psychologist at Children's Hospital of Philadelphia, and Dr. Stephanie Doupnik, a pediatric hospitalist at Children's Hospital of Philadelphia. They are also both faculty members here at Policy Lab. I'm going to hand it over to Dr. Williamson to get us started.
Great. I'm so excited to be able to talk about integration of behavioral health services into primary care settings. We have an incredible unmet behavioral health service need among children and adolescents in this country. Up to 10% of preschoolers have social, emotional, and behavioral concerns, which place them at risk for poor development later in life. In addition, the majority of mental health problems, and by that I mean things like depression, anxiety, and ADHD or attention deficit hyperactivity disorder, begin by adolescence or young adulthood. At the same time, a number of children also experience sleep problems. Up to 40% of children will have a hard time with falling asleep, staying asleep, or daytime sleepiness at some point in their life. If you have a mental health concern, you're also more likely to have one of these types of sleep disturbances. Despite having effective treatments for both sleep problems as well as behavioral health concerns, only about 1 in 5 youth ever receive a behavioral health treatment, even though they need help. And they also have a significant delay in when they actually receive care. So unfortunately, kids tend to receive mental health treatment up to 10 years after they first started having symptoms. So what's going on? Why do we have such a big gap in services for youth? Well, first, unfortunately, there are a few child and adolescent mental health providers, such as psychologists, social workers, and psychiatrists that are available to treat kids. In addition, at community sites who do have these providers, there are often long waiting lists to be seen. Insurance coverage can also be an issue, with some families struggling to get their services covered by these companies. And even though there is an increased incidence of mental health concerns among children, so more people are aware of these problems, there's still stigma around receiving treatment. One of the ways to help with these gaps in our care delivery is to provide services in settings where children are regularly seen and can regularly access care. One such setting is primary care. In fact, a number of pediatricians do say that their patients talk to them a lot about mental health problems, but they struggle with options about where to send them for care. Integrated behavioral health in primary care refers to short-term therapy services for mental health problems, and these services are provided by social workers, psychologists, or psychiatrists who are working alongside the pediatrician and other staff members in the primary care setting. What does this actually look like in practice? Well, we have a number of research and practice initiatives here at CHOP that are very exciting. On the research side, we have a recently funded large-scale study led by Dr. Jennifer Mattone, who's also a Policy Lab faculty member, as well as Dr. Thomas Power. And this study is on improving access to care for children with ADHD. This study will look at the effects of a behavioral treatment impacting children with ADHD and implemented in primary care. I also have ongoing research related to implementing behavioral sleep intervention for preschoolers who are having a hard time falling asleep, staying asleep, or not getting enough sleep. The goal of this study is to see whether an intervention implemented in the primary care setting can help improve child sleep as well as behavior. And finally, we have a clinical service delivery through Healthy Minds, Healthy Kids. This program provides brief primary care-based services through psychologists, social workers, and psychiatrists at a number of primary care sites in the city as well as in the suburbs. And service delivery sites are expanding every day. Currently, we have providers at Cobbs Creek, Carabots, South Philadelphia, Haverford, High Point, and many others, with more being added this year. A recent case example from when I was providing services in behavioral health and primary care can help us understand how these services can make a difference in the lives of families. Here's a case example from a patient I saw who was a 4-year-old boy, had been having temper tantrums both at home and at school. At school, these temper tantrums were getting so bad that the school was threatening to expel him from preschool. The pediatrician and the family had been really concerned about these behaviors for over a year, but there were barriers in accessing outpatient referrals. The family didn't have reliable transportation to get to the care site. In addition, there were also concerns about the child's sleep, including stalling and tantrums at bedtime and having a tough time sleeping alone. So over the course of 6 sessions after they were referred to the Healthy Minds, Healthy Kids program, they started having much better behavior during the day, so less tantrums at home and at school, and better night sleep as well. And through that, we were able to coordinate with both the preschool teachers as well as the primary care provider. In the future, if this family is having trouble again with child behavior, maybe when he transitions between grades or something else happens in the family, the primary care provider can easily refer them back to the Healthy Minds, Healthy Kids program. So that's an example of integrated behavioral health in the primary care setting. And now I'll turn it over to Dr. Doupnik to talk more about integrating into the hospital context.
Thank you. I'm very excited to have the opportunity to talk about this topic. The first thing I'll show you here is the growth and need for behavioral health treatment in hospitalizations for kids. So what you see here on the left is a graph that shows the growth in the number of patients who are hospitalized in pediatric hospitals who have a psychiatric diagnosis. And you can see that between 2005 and 2014, there was 100% growth, meaning the number of kids doubled who had a psychiatric diagnosis. On the right, you see that there's even a little bit more nuance to the story. And you see that kids who had only a psychiatric condition, which is the gray line at the bottom with the squares as markers, you see that the number of kids who had only a psychiatric condition and no medical condition stayed relatively stable. Meanwhile, the number of kids who had both a psychiatric and a medical condition, that's the medium gray line with the triangles, who were in the hospital primarily for their psychiatric condition, grew substantially. And then also the number of kids who had a medical condition who were primarily in the hospital for a medical condition and also had a psychiatric condition, that's the nearly black line with the round markers, those kids were also, the number of those kids also grew substantially in that time frame. And the reason I highlight this is just to show that the need for behavioral health care during hospitalization is great, and that it affects both kids who are hospitalized primarily for their behavioral health condition, but also that it substantially affects kids who have a medical illness requiring them to be hospitalized. Now, among the kids who do have a behavioral health condition who are hospitalized, unfortunately, their hospital outcomes are worse than those of their peers who don't have a behavioral health condition. I've conducted a series of studies to understand exactly in what ways their hospital outcomes are different, and we found that kids who have behavioral health conditions have nearly twice the risk of medical complications. They have up to 20% longer hospital stays. We know that communication challenges exist between medical teams and families. And we know that after kids with behavioral health conditions go home from the hospital, they have a higher risk of needing to be rehospitalized. And our research has shown us that, that most likely all of these findings are related to the complexity of caring for kids who have both a behavioral health condition and a medical condition, and the transition between different sites of care, between hospital care and between behavioral health care, which isn't always well integrated into hospital care. Now, to address some of these needs, there are ongoing initiatives to integrate behavioral health care into children's hospitals. And a couple of these initiatives are big priorities. Now, the first is screening for high-risk behavioral health conditions. During a hospitalization, we have a unique opportunity to screen for conditions that could affect a child's health and safety in the short term. So that includes suicide risk, meaning kids who are having suicidal thoughts or suicidal behaviors, and also access to firearms, either in kids who are at risk of doing violence to themselves or in kids who are at risk of violence in their communities. The second category of initiatives is integrating behavioral health services into hospital care. And so for kids who have that overlap between their medical and their behavioral health condition, it's important for the clinical team to have representation with clinicians who are specialists in all the aspects of care that the child needs. So that includes integrating psychologists, psychiatrists, child life specialists, and social workers into clinical teams that historically have primarily been composed of medical clinicians like pediatricians or pediatric surgeons. And then finally, we know that behavioral health needs don't end with the hospitalization. And so a big focus of efforts to integrate behavioral health services into children's hospital care include efforts to ensure that behavioral health services continue after the hospitalization. That includes for kids who are at high risk having a safety plan so that if they were to have a behavioral health crisis after leaving the hospital, they know exactly what to do in that moment. And then the second is ensuring that kids are accessing appropriate behavioral health services for their ongoing routine behavioral health needs. And in some cases, that might include behavioral health services in primary care, like those that Dr. Williamson talked about. I'll share with you now an example of a case of a child who was cared for with integrated medical and behavioral services. This was a 15-year-old boy who was hospitalized in a psychiatric unit due to suicidal thoughts. And while he was there, he noticed a mass in his abdomen. That psychiatric unit had a medical pediatrician who initiated a transfer to CHOP so that the patient could have a thorough medical evaluation. He was admitted to the CHOP Medical Behavioral Unit, which is a unique 10-bed unit at CHOP where we have an integrated medical and psychosocial team that includes all of the medical specialties available at CHOP and also all of the psychosocial disciplines, including psychology, psychiatry, social work, and behavioral analysis. And what we were able to do for this child is, at the same time while the medical team was performing the medical evaluation for the mass in his abdomen, the integrated behavioral health team was able to continue with the care that he needed due to his suicidal thoughts. We were able to keep him safe from self-harm and able to help him cope with the stress of a hospitalization and a new diagnosis. Ultimately, the patient was diagnosed with lymphoma and began treatment with CHOP Oncology. And the medical behavioral unit team was able to help him arrange to have ongoing behavioral health care after the hospitalization was over. So our key takeaways are that untreated child mental health concerns are extremely common in primary care and inpatient medical settings.
And as we hope we've shown you, integrating behavioral health services into these settings can help improve access to care, child mental health outcomes, and importantly, hospitalization rates.
And finally, we hope that we've shown you that there are some new initiatives at CHOP that focus on providing and evaluating integrated behavioral health services.
Great. Thank you both so much for that presentation. For folks who are joining us, if you'd like to access any of our other webinars in the series, you can visit our website at policylab.chop.edu.